Good afternoon. Welcome to our session on epilepsy. My name is Dr. Agnes Matthew. I'm a pediatric neurologist with Sagar Hospitals. Today I would like to introduce my friends and colleagues, Dr. Kalyani Karkare, who is an epilepsy specialist. She's an epileptologist and a neurologist. And we have with us Dr. Vivekananda, who is a neurologist, an adult neurologist. Dr. Vivek, would you mind telling us something about the type of epilepsies that you generally see?
I welcome all the viewers. Today, as we are discussing regarding the epilepsy, or in common terms what we call it as seizures or fits. So, as far as the adult seizures or epilepsy is considered, we tend to see basically two kind of epilepsies. One is which is primary, and the second one is which is usually due to some other reasons, or we call it as secondary seizures. Usually whatever we see in our clinical practice is around both the primary and the secondary causes will be around approximately around 50% in our clinical practice. So depending upon the reason, or in the secondary epilepsies, the treatment and other things will differ. So it is very much important for us to evaluate and to decide whether it belongs to the primary or it is secondary, and which is very much true even in pediatric age group also.
You're absolutely right. So in the pediatric age group, what we normally tend to see is that it is not normal to have epilepsy. So epilepsy per se, it's not a disease. We like to call them epilepsies. They're a group of things. And in children, there's another aspect to it. The normal characteristic, or the main feature of a developing child's brain is basically development. The child is growing, developing its personality, and doing everything that he or she should be doing, and gaining skills to become a fully functional adult. If the developing brain is susceptible to seizures, that brain is likely to be damaged by it itself, depending on the developmental age of seizures. This brings in what we call as developmental epilepsy, that aspect. So we need to pay a lot of attention to the developmental aspect of it. This means that the younger the child, the more seriously we take it when they have epilepsy, especially under 2s. Now, while speaking about that, I'd like to ask Dr. Kalyani something else. Most of the epilepsies we see are treatable.
Mm-hmm. Yes.
Most of them. In general public, it's a big problem. It's not a small problem. It's not a rare disease. But as a niche specialist, as somebody who is an epileptologist, you would get that very small percentage of patients with epilepsy who are really difficult to treat.
Yeah. So yes, as Anne says, most of the epilepsies are treatable. That means if we find an appropriate drug to the appropriate epilepsy syndrome, that means whenever we see a patient of epilepsy, we try to categorize them into some known kinds of epilepsy, because there are some drugs which are indicated in specific type of seizures. So most of the patients are treatable by the drugs, the appropriate drug chosen in appropriate dosage, and most of them would require a treatment of 2 to 3 years. And if they are seizure free, then depending upon the clinical judgment, we would reduce their drugs and see how do they do.
So you mean to say the evaluation is very important in treating?
It is. So whenever a patient of seizure comes to us, and the minimum investigation is EEG. The scan may or may not be needed depending upon what we think it's a type of seizure. But what Anne was mentioning is that yes, as a epileptologist, we tend to see the more difficult cases too, like a subset of patients who may not be responsive to the usual first 2 line of drugs which we choose. So those cases, what we call it as drug resistant epilepsy or refractory epilepsy. So it's a very small proportion of patients, but they need to be identified rightly, because sometimes it also happens that those whom we are labeling as drug resistance or refractory are probably not on a right drug,
the right choice,
in the right proportion. If the combination of the drug is not right, the dose is not right, and that's why, or the patient's compliance, which we always emphasize in epilepsy, that adequate sleep and drug compliance, that means taking your medicines regularly, is the cornerstone of freedom from seizures. So all these factors, if we have ruled out that patient is taking drug regularly, these are appropriately chosen drugs, they are taking in proper amount, great combination, still the patient continues to have seizures after use of 2 drugs, then we refer them at drug resistance, and they may take a separate path. So they may fall into a surgical candidacy or even other ways of treating them. Like Anne would be a better person to say, like we use other non-pharmacological ways, no, in some kind of difficult epilepsy, like diet and...
Is it same even in the pediatric group?
In the pediatric group, it is exactly the same.
Is it like, do you require scan for all who comes?
So,
or
no,
it depends?
So before we go on to the other, so I would like to speak about the ketogenic diet, and then we'll come back to the other points. So,
because in the general public, they are very much, means whether it is required or not. Because many times in our clinic practice we see, when you prescribe them the scan, they say, is it required? Or they will come to us telling, doctor, please do a scan.
Do a scan.
Both are wrong, as we all know.
Yes.
So as we all said, so one of the messages we want you, the viewers, to take home is, epilepsy is not a disease. Epilepsy is just a sign that the brain, there is something wrong and it is reacting wrongly. So we need to treat it just like fever is not a disease. Fever is a sign that usually body is fighting infection.
Yes.
So the same way, as Dr. Vivek initially said, we are categorizing into primary, secondary.
Yes.
In the pediatric age group, the younger they are, we know that there is something seriously wrong with them. In the sense, it could be genetic diseases which cause them to have it, or it could be small tumors, or having. Many of us have birthmarks. If you have a birthmark in the wrong place in the brain at the right time, now whatever you do, just giving medicines is not going to help. They go into surgical candidacy.
Correct.
You need to cut and remove it. So thinking about cutting and removing it for a 9-month-old baby might sound terrible, but it means that you're saving the brain development and improving the intelligence of that child.
You're treating the cause.
You're treating the cause and giving
that
them
is more
seizure
important.
freedom and giving them their best potential. So Dr. Vivek, you've rightly highlighted saying when to do MRI and all of those things. People often come with this. So I think would you agree with me that the solution for this is educating families and telling them there's no...
Definitely, because if it comes in the pediatric age group, definitely they should have the knowledge
especially
of that.
under 2s.
Yes, under so
2s.
in the adult it is a different issue.
Yeah.
Different issue because it depends upon the cause. But in the pediatric, I think that is more important. That's more important.
So over 2s, we have a cutoff. We say under 2s. Over 2s, we don't. But again, it depends. So over 2s, some of the cutoffs are if they have one single good medicine, you haven't responded as we expect them. Because as Dr. Kalyani was mentioning and as Dr. Vivek was mentioning, most seizures are treatable. Majority of them are treatable.
Yes.
The ones who do not respond to a well-chosen medicine, we start wondering, is there something else going on? That is when we tend to do.
Yeah.
We tend to do MRI. CTs usually do not help unless it is.
That is more important to the public.
Yeah, CTs
because
usually do not help.
Even when they come because of the cost issues, they say, doctor, please do CT, why MRI?
Yeah.
So I think that should be very clear from our
So this is an interesting thing from a pediatric perspective. If you do CTs for under 4s, you reduce the IQ of the child.
Okay, that's also very important.
That's also there.
That's also important.
Neither do you get an answer.
Yes.
And you're causing harm as well.
Yes.
So, but then that doesn't mean that we never do a CT. In emergencies, we do a CT. But those are in emergencies.
Yes.
Yeah.
So, bearing in mind, do you see patients? You must be seeing patients whom you are sending for ketogenic diet. Do you have a lot of patients with non-pharmacological means other than surgical things? In the pediatric age group, we tend to have quite a big proportion of children on ketogenic diet, non-pharmacological, what Dr. Kalyani was mentioning. Other modalities are VNS.
Is this true even in the adult epilepsies also?
You can use it, but the problem is compliance.
Okay, but is it going to help even in the adults? No.
Yes, it will.
Okay.
So ketogenic diet helps in most, but the thing with ketogenic diet is it's very good, but it means that you can't even eat, say you go to Tirupati and you get prasada, you can't eat that because that will break your ketosis. You are not supposed to eat any carbohydrate.
Okay.
You are not even supposed to use...
You mean to say do you come lifelong or it is
No, it's not lifelong.
Few years?
So usually we give it for a few years. So
okay.
An example is a child I just saw today who had been diagnosed as someone who's got autism, but and epilepsy, really difficult epilepsy. We did a CSF study, a lumbar puncture, and we found out that she has glucose transporter deficiency.
Okay.
So the moment we started her on ketogenic diet, we were able to wean off anti-epileptics.
That's
her autism
fantastic.
improved.
That's fantastic, actually.
Very, very few times, but then it would be really bad if we miss out things like that.
So that's what she says, that evaluation is very important.
Yeah,
Evaluation is very important.
The same with adults, you must be seeing
Yes,
evaluation and picking up tumors and stuff like that.
Yes, definitely.
Yeah.
See, in adults, I think the scan is mandatory.
Oh yes.
Yeah?
True.
Yes, not like in pediatric age group.
Yeah. True.
So
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 yes.
what I think another thing that would be saying would be the genetics of epilepsy. When you're saying earlier, if they start, it usually means that the idiopathic generalized, the what we expect as things that are not focal, things that don't need surgeries.
Yeah.
Would you agree with that?
Yeah. So generally the dictum is, though it may not be exactly, like if someone is getting their first generalized seizure, and I'm talking not about kids, generally in the second decade, like around 16, 17, they're getting their first generalized, that means the convulsion most of the people know. If they get it generally in sleep or near the early awakening period, in an otherwise normal person, then it's unlikely that their scan is going to show something abnormal. So before the age of 25, generally if they have a single or infrequent generalized seizures in the night or on early morning, then unlikely that they have a focus. But that can be seen in cases of NCC, the neurocystic psychosis. So one of the common causes of seizures, like
in our country,
like a one attack in an absolutely normal person is NCC, and that's why it's better that we get at least a minimum CT scan, if not MRI, in those cases when we are not very suspicious of finding a focality. And sometimes other history, like sometimes what happens that people are highlighting only the bigger seizures, the generalized ones. But then if we ask them the questions that do you have jerks in the morning, do you have like something slipping out of your hand sometimes in the morning, with these leading questions they give us that yes,
much more information.
Yeah, and if it turns out to be so, that's a typical kind of epilepsy which we say as juvenile myoclonic epilepsy, where it's a generalized epilepsy. So scan is going to be normal, but we have to start a right drug, and probably they may need medicine for a longer time as opposed to our usual.
And one more thing, when do they require? Means the public will always wants to know. Always you require an EEG in adults whenever we treat that along with the scan. We require EEG.
Yeah. So actually, the American Epilepsy Association, the guidelines are even a single episode of seizure, EEG is mandatory. Scan may or may not be mandatory. So EEG is mandatory except in kids where we are thinking of febrile seizures or even benign Rolandic. So there are some types of seizures, especially in childhood, which are like so known that they don't need EEG, but otherwise any person who is coming even with single, you may not start treatment with a single attack of seizure, but a single attack of seizure also needs a EEG as a baseline thing, and depending upon your clinical suspicion you can ask for a scan.
So and the another thing you brought up now, whenever a patient comes to us, doctor, it's only one episode. Do you really want to treat?
Yes.
When scan is normal, EEG is normal, blood tests are normal, do you want to treat? See, so this question is where every time we land up in the adult test. So in children, if it is only one episode, means do you?
Yes, we do. So this is again.
No, is it same even in the adult?
This seems to be a universal thing. So as Dr. Kalyani mentioned, if we call them either epilepsy or not epilepsy, febrile seizure is not epilepsy.
Yeah.
So we do not use the same yardstick as we are using with epilepsy. For epilepsy, as Dr. Kalyani was mentioning and earlier Dr. Vivek was mentioning, we are wanting to put them into categories of what is causing them. Electroclinical syndromes we call them. So if we have an electroclinical syndrome, even for benign Rolandic, we would still need the EEG to make the diagnosis.
True.
So otherwise, in children we don't like to do unnecessary EEGs for febrile seizures because you may have normal children with spikes.
Some spikes,
and so we don't want to do it. So the diagnosis for most of our things, we make it on history.
True.
But the younger the child, if there are doubts, we end up doing EEG. That would be the bare minimum.
And one more information, if you like to give, is it required to treat febrile seizures? Because so many times we see people treating and sending to us.
If it is really febrile seizures, we do
that's
not.
one you mentioned.
Febrile seizures do not cause damage to the brain, but the problem is there is a very small proportion of children with epilepsy who are hiding in that group. They need to be teased out, but majority of, if they are really febrile seizures, they don't need to be treated because the treating drugs can cause they do have side effects.
If-
They
if-
have
if there
impact
is-
on IQ and memory.
If there is a repeated episodes of
Repeated episodes
yes,
of seizures,
yes.
which is what would be, say, even if some people get only once in their lifetime, some people get 5 to 20 times.
Yes.
All of them, none of them are going to be impacting the brain development.
Okay, so you mean to say categorically that it doesn't require any
No,
treatment?
it doesn't. We used to treat them in the past. Now we know that it does not affect development of the child. It does not affect the IQ of the child and its future potential. So we don't treat them. Categorically, we do not treat them. And that is also why we don't investigate them. As we were mentioning earlier, in children, what you're mostly worried about is the cause. And majority of us, as Dr. Kalyani was mentioning as well, majority of the epilepsies happen early. When they come to you, by the time they come to you, if it is later adulthood, you are worried about other things.
Yeah.
For us, we are worried about development alone, and what is the underlying cause. How well they do is based on the underlying cause.
True.
Yeah.
And
Would you agree on that?
Yes, definitely. That's why the evaluation is very important. I
Yeah.
always stress upon the evaluation
So
of
what
any-
about the social aspects of epilepsy?
Yes. See, before that, I would like to ask one. Whenever a patient comes with one episode of seizures in adult group, what is in your practice? Do you like to treat one episode with none of the investigations or evaluation points out for some
Okay.
cause? Do in your
Okay.
personal experience and whatever you
Okay,
practice?
so if it's a single episode of seizure and if we have done EEG, MRI, it's normal. There is no family history of seizures. So like absolutely normal person, no other contributory factors, then it's always a discussion between the parent and the treating neurologist. So we, like in my case, like this is what I go ahead, like I would like to know that what are the risks if this patient is not given drugs and he remains unprotected. What are the risks of hurting the patient? That means if a person
If
is
it
staying
repeats.
away from the family, like if the college going student is staying away from the family in a hostel, and if he gets another episode of seizure and no one is going to see him, if
For
he's
example, in
into-
drivers.
Huh,
If
so
they're
like profession
Yes.
is important. Like if it's something, you are a professional driver, that means you are a taxi driver, you are a truck driver and bus driver, there is no way that even a single episode of seizure can be allowed. So that has to be treated. But if you are with your family, a student, and the seizure which happened to you was only nocturnal, so the chances of falling on the road, no, in the middle of something or near the gas, those kind of things, if we are ruling out that, I still give option that there is an option that we can follow you up. The risk of having seizure, because this is also one rule that whatever drugs we are giving to treat even that single episode of seizure are not protective beyond a long-term follow-up. Like they are protective only for first 2 years. So there are studies which have shown that if you have started the treatment and if you have not started the treatment, 5 years down the line, whether any change is there in the incidence of epilepsy in them, and there is none. So these drugs are not like neuroprotective in the way that if you treat earliest, you are going to prevent a future epilepsy. So that has not been proven, and that's why each patient we have to individualize depending upon their occupation, depending upon their safety potential,
Yes.
and we'll decide that whether this patient would need treatment.
So Dr. Kalyani, that is a good point, but with that, again I'll bring back to my point with regard to social aspects, especially the stigma and the and more with women
See,
and epilepsy.
coming to the social things, that's where I as you mentioned in the initial stages,
Yeah.
the parents and the society has to be made them to understand what it is. Is it actually a taboo or a stigma or whatever it is? So we need to educate the public also. That's why the media, the social media and the electronic other medias, and including doctors,
Including what we're doing now.
yes, not what we're doing now,
Yeah.
will come into effect effectively if we give them. So it is very important for the general public to be educated really regarding that. I think that is the most important social thing what we have to do.
Yeah, this
So-
commonly happens, like as you said, in case of women, the common question is, can they get married?
Yeah.
And whether their kids are going to have the seizures what the mother has. And generally before the alliance, people ask that how can they disclose?
We
that-
see this at 9-year-old coming with a seizure.
Oh, okay.
It's still like she's a girl
Oh my
having
god.
seizure. Yeah.
Yeah, so that's the problem with the society. The funniest thing, like we generally tell them that the generally a seizure would be precipitated if you have not taken your tablet, or if you have not slept well, and if you are stressed. All three things can happen when you are getting married, you know, that the functions are going on, the preparations are going on, people are in full Josh, and they forget to take one tablet, and they are stressed about the preparations and the prior night and the whole preparation, and exactly on the day of marriage you may get a seizure, which is worse than having the whole idea that there is a seizure in the background, you are taking it calmly and you are facing it, which also happens with exam going students. Like they think that, oh, maybe this tablet is making me sleepy, so I will not take it during the exam time. And what happens is, on the day of exam they get a seizure because they skipped the tablet and they did not sleep well. So we need to understand that this is not something to be hidden. Like, there is nothing wrong basically about your brain. It's a excessive abnormal electrical activity. The activity which is normally present in your brain gets excessive and happens, all the neurons in your brain are firing at one time. So there is nothing to be hidden. Like, I feel that people talk about their diabetes, BP and bypass as a status symbol, like 2 lakh ka stent dala and 3 lakh ka stent dala, you know. So we are not scared about this, talking about our other diseases which may be actually lifestyle related. Like, probably you didn't exercise, probably you were eating junk food and you landed up in something, but we are not worried about that. We are worried about the thing, we are worried about the thing which is not in my hand, like some electrical current. So I feel like those 2 minutes of fit cannot decide other 24 hours of your life at all. That person is absolutely normal, like any other person in the population.
And as you rightly said, they can lead a normal life.
Exactly.
So
and do you want to say something regarding the pregnancy related with that? Means there are so many questions.
Yeah, true. So the only thing we tell in the females of reproductive group, as we say, that those who are going to marry and have, so we tell them from beginning that if there is a if you are going to plan a pregnancy before conception, you should come back to us, tell your gynecologist, obstetrician as well as to us that there is a plan of pregnancy, so that some drugs, if they are not suitable for you because they may be harmful, we have to change them. Most of the drugs are not, so we can continue them, and they need to be supplemented by a vitamin.
You mean to say that present day medications and the sophistication what we got to treat the epilepsy, pregnancies absolutely can carry on?
Yeah, sure. Yeah, true. That's the message to be, that they can have a normal life, including a normal job, any profession except from the professional drivers or pilot, those kind of risk-taking professions. Apart from that, any job can be pursued. They can get married, they can have a safe pregnancy. The kids, they do not inherit epilepsy. There are very few epilepsies which have it's genetic or inheritance, basically, not even genetic. So they can lead, everyone can lead an absolutely normal life and carry their all roles of life without any problem.
So what all of us here would like to give as a message to all of you listening to us is that epilepsy is mostly curable, mostly treatable, and as all of us said here,
evaluation is important.
Evaluation is very, very important. Evaluation is important, and it's also important that we don't hide this and try and not make this the definition of who we are.
Exactly.
So hopefully this would encourage people around to seek better health and live well.
Sure.
Okay. Thank you.
Thank you.
Bye-bye.
Thank you all.
Thank you.
You were the moderator, I was the moderator. He was hijacking the questions from me.